Welcome to AETCM, the Business Medicine channel. Today we're discussing about a middle-aged man who was brought to ER in an unresponsive state. So, a middle-aged looking man was brought to ER in an unresponsive state by the general public. He was actually found lying unresponsive on the road near to a hospital about 10 minutes back, and within 10 minutes they brought the patient to a hospital. So on the initial arrival, on arrival he was found to be unresponsive. So immediately he was not breathing, and on checking the pulse, he was not having a carotid pulse. So immediately started the CPR, and as soon as the staff arrived, I handed over the assignments to different staff. So one person was handed over CPR to continue. Another person was given to take control of the airway with ambu ventilation. So they were continuing CPR with 30:2 compression ratio, and another person was asked to secure an IV access. Also, one more person we had available, she was asked to conduct the patient to a defibrillator and tell me once it is ready. And one person was asked to note all the events that was happening and also to record the drugs given with the timings. And also one more person we had extra available. We asked her to talk with anyone who was available outside to get a history of what happened.
Okay.
So basically, we had a team prepared. The CPR is ongoing, and I am assuming as the team leader was continuing the CPR.
Okay, excellent.
So far we have a middle-aged man brought in unresponsive state without pulse. So as soon as the machine was ready,
the defibrillator was connected
and was ready. The staff told was ready, so we stopped the CPR and analyzed the rhythm. The machine was showing a ventricular fibrillation.
Okay, so you have a shockable rhythm here, whether it's a wide complex rhythm. It can be VFET, whatever be that, we are seeing a wide complex rhythm and it is a shockable rhythm and the patient is in cardiac arrest.
So immediately I asked the staff to continue CPR.
Yes.
And then again, the person who was in charge of defibrillator, I asked him to charge the maximum joules available. So in our machine, we had 270 joules as the maximum dose. So she was asked to charge up to the maximum. And also to apply this thing, we had paddles. So apply gel over the paddles. And once it is ready, asked to clear all the people who are in CPR and to give shock.
So before that, you can do the charging part also. You can charge and keep it ready before stopping the CPR. So we are again gaining another 2 to 3 seconds.
So the defibrillator was charged the maximum joules available is 270 joules, and once it was ready, all the team members were cleared from the scene by counting 1, 2, 3, and then we shocked the patient.
So first shock was delivered.
So we had a non-perfusing wide complex tachycardia, and we delivered the first shock, and then again continued our CPR. So the person who went to take the history came back. So basically what she found was this person was actually found lying unresponsive on the road and found by some general public who was walking nearby. And about 10-15 minutes he was lying on the ground.
Okay.
So they brought him here for further management. But they don't know him personally or
we don't have any other history. That is the only thing that is available right now. Fine.
So no medical history or anything we know.
So that's fine. We are doing of the code, so we can just continue with the code.
So 2 minutes have passed and they again stop the CPR and again reassess the rhythm. Again it is showing another VF. So we continued with the CPR and asked the staff to charge again the maximum joules. So once it was ready, again we gave shock of 270 joules. So by this time actually we were able to secure one 18 gauge cannula on the right hand, and through this I asked to give 1 milligram epinephrine, 1 in 1000 dilution was given, and followed by a 20 ml nosocomial flush was given.
Okay.
And also asked the recorder to remind to give every 3 to 5 minutes one more dose as required. And since the patient was in cardiac arrest with an airway a compromised state,
after second shock, what else you want to do at this point of time? You're having a shockable rhythm.
After second shock, actually we have to think about it's more in favor of probable refractory shock also. So we can ask one staff to arrange for 300 milligram amiodarone. In case the next cycle is again showing a shockable rhythm, we have to give amiodarone.
Okay.
So I asked one patient to arrange for 300 milligram amiodarone, and in meantime actually I also asked the staff to arrange for intubation. So with a size 8 ET tube, intubated the patient and fixed it around 20 angle of mouth.
Okay.
And also the position was confirmed by 5-point auscultation. And also
intubation will stop this chest compression, or
the visualization was actually done during CPR, and as soon as we were able to properly visualize, we stopped the compression, and within 10 seconds we were able to pass the tube and secure it. So by that actually we were able to minimize the time for stopping the CPR. So the airway was secured by ET tube, and now the compression has been changed to continuous compressions at a rate of 100 to 120, and breath was given every 6 seconds.
Excellent. Okay.
And we connected to ETCO to monitor, and it was showing about 12 to 15 in the monitor. And so again CPR continued, and meantime actually I asked one staff to take and get an ABG.
Okay.
The sample we got back was on VBG, but it was showing severe metabolic acidosis with a hyperkalemia of 5.6.
What was the pH?
pH was 7.02
7.02.
with a bicarb of 14.
Okay.
So this patient we gave 10% 10 ml calcium gluconate was given as bolus, followed by glucose insulin bolus was also given.
What was the potassium?
Potassium was 5.6.
5.6. See, again, the question asked here is that 5.6. And are you sure that it is 5.6? That is the thing. But in a cardiac arrest scenario, you are saying something. So you try, treat, and let's see whether the patient is coming back or not. Usually, it can be lifestyle. There can be a lot of arguments for that hyperkalemia. But still, you are having a patient in cardiac arrest. There is no harm in giving a calcium gluconate at this point of time. So we can try by giving a one shot of calcium gluconate, 10 ml, 10%. We are seeing some hyperkalemia at this point of time. And the question should not come why he developed hyperkalemia. All those things you can think later. But you are seeing something, you try treating that. So routinely, when we are doing in a code and all, sometimes you might get a lysed sample. So we cannot 100% say that hyperkalemia is a cause of cardiac arrest. Something would have super added to it. So we are seeing it. Let's try treating that. Okay.
So after flushing the cannula, we also give a 50 mg of sodium bicarbonate.
50 milligram soda bicarbonate. See, again in a discussion point of view, when you are ideally looking 7 pH, whether you want to give a bicarbonate or not. There are a lot of recommendation less than 6.9, 6.9, 6.8, but this patient is in cardiac arrest. It is 7 pH and you are also seeing a hyperkalemia associated with that. So again, you can try giving 50 to 100 milligrams of soda bicarbonate, but these are all not 100% evidence proven, but we can attribute to a hyperkalemic cardiac arrest. That is the reason why we gave a soda bicarbonate. Again, you have to check for the preparation, whether it's a 7.8 or an 8.2%. So, if it is 8.2, you will get 1 ml is 1 milligram preparation. So, other one, it will be 1 ml will be 0.8 milligram. That is the only subtle difference. So, approximately 50 ml of soda bicarbonate you can give for this patient, which we had given for this patient here. Okay.
So we gave calcium gluconate, insulin dextrose, and also soda bicarbonate, and the CPR was continued. But thinking about the other causes of reversible, like causes of cardiac arrest.
So we have given 2 shocks for this patient.
2 shocks.
And we are continuing CPR. Meanwhile, we got this result. We gave an amiodarone. We gave amiodarone.
No.
We haven't given amiodarone till now. Since only 2 shocks have been passed, we got a hyperkalemia. We gave a calcium gluconate and we gave an order for soda bicarbonate also. Okay.
So again, 2 minutes have passed. Again, reassessing the rhythm, it's again VF only.
Okay.
So we again shocked the patient, and this time I gave 300 milligram of amiodarone.
300 mg of amiodarone. So the thing is that when the amiodarone should be given after the third shock, there is no confusion. But you can start considering amiodarone after the second shock, but deliver it after the third shock. So keep the nurse to prepare it ready and keep it ready. And after the third shock, you can give amiodarone. So that is a clarity. Fine.
So as per the newer guidelines, actually we can also give, instead of this lignocaine can also begin on 1.5.
So whichever is available, amiodarone, well and good. If not, lignocaine.
So this was the 300 milligram was given and CPR again continued. And after the next cycle, like we again stopped to check the pulse, monitor was showing an organized rhythm. We
are starting to get an organizing rhythm. So what will you do when you see an organized rhythm?
First thing is to check for pulse.
Excellent.
So this pulse, in this case actually the pulse was palpable.
Okay.
So the patient has attained ROSC or
suppose there is no palpable pulse. The patient is in PEA. So we need to continue CPR and every 3 to 5 minutes just continue giving adrenaline. Okay.
So this patient by the 4th cycle we have got a palpable rhythm. There is so patient is attained ROSC or return of spontaneous circulation. So the current situation, patient was in a refractory VF by the
3 shocks and after amiodarone and he improved.
And he reverted to a organized with rhythm with pulse. So we are now going to the post cardiac arrest care. So starting from airway is already secured by the 82. So we once again confirm the position by the 5-point auscultation, and also actually we are able to hear Krebs bilaterally at this point. And ETCO2 again confirmed by about 45 was the ETCO2 value. So both confirm the position of the ET tube, and breathing part SpO2 was maintaining 100% with about 60% FiO2.
So you can still come down on your FiO2. We don't want 100% exactly. We are okay with 95 and above. 95 to 99 we are acceptable.
So we connected the patient to a ventilator at this point, And again, continue with this thing. So, airway breathing and circulatory part, he had a heart rate of 118 per minute, and BP record was 70/50. But since we actually heard bilateral crepitations, we were in suspicion the patient could be in like an early heart failure also. So we didn't give for any aggressive fluid.
Definitely, it is a failed heart, which we have revived. So definitely, it's a heart failure.
So we didn't want to give any more like aggressive fluids. So we started him on noradrenaline.
But I am not denying the fact that you should be avoiding the fluid. You can still give a bolus, and because already you have secured the airway. The worst thing that you are going to get is a pulmonary edema because the airway is already secured. So that point is covered. So you can still definitely give a 500 ml of fluid bolus, and because there will be some intravascular fluid depletion will be there. So you can give a 500 ml of fluid, and then you start thinking of starting your whatever, whether it's a vasopressor or an inotropic agent, depending upon the blood pressure. So it is 70/40. We would have started a vasopressor like noradrenaline, bringing the BP up, and then maybe adding an inotrope, depending upon the scenario.
This patient actually, we started him on noradrenaline infusion was started and again continued. Disability part, he was not responding to commands. This was again E1 BT M1. But this point actually we are not able to like go for aggressive TTM because of this thing.
What is the one investigation that you wanted at this point of time? A 12-lead ECG.
12-lead ECG.
That is the next thing. So you are seeing a shockable rhythm, VT or a VF. The most important reason why he would develop this will be an ACS. So take a 12-lead ECG and look for any STT changes. If there is an STT changes, initiate TTM and the patient should be in the cath lab.
So ECG was taken, it was not showing any acute ST elevation, but multiple inversions were there from V1 to V6.
Because again, 3 times we have defibrillated this patient. So again, it is very difficult to have the classical STT changes in the ECG. Unless and until proven, this patient will be having an acute coronary syndrome, which would have happened. He would have had a chest pain and he would have collapsed and he went into a VT or a VF. From there, he was brought to the emergency and we have revived him. And he is a candidate that should be going to the cath lab for a primary PCI.
So we also took an echo. Echo was showing RWMA with apex severely hypokinetic and thin. And also apical septum was also hypokinetic. Almost all segments were severely hypokinetic and thin with severe LV dysfunction, and mild MR and trivial AR was also noted. So after our early management, so again repeating vitals, now he is maintaining 100% saturation on ventilator. Heart rate is 124 now with BP of 170 on noradrenaline 12 ml per hour, which is about 0.3 microgram per kilogram dosage. So with support he is maintaining. So after this we shifted him for cath lab for an early PCI.
Early PCI. So what happened to him later on?
Thing is actually post after cath lab he is now undergoing like post cardiac care in
Post in the CCU. Suppose we had a patient who have presented with a shockable rhythm here. So when we have a shockable rhythm, our priority is to defibrillate as early as possible. So here the adrenaline is not the priority. When you have a shockable rhythm, priority remains for the defibrillation. And on the other side, whether we have a asystole and PA, CPR followed by adrenaline. When you said regarding the management, we gave adrenaline only later. After second cycle of CPR only, after second assessment only we gave adrenaline. But we did 2 defibrillation prior to that. So only after that only the role of adrenaline will come. Again, when you have, what will you would have done when you have a patient with refractory VF? You have given amiodarone, still he is not improving. What you would have done? What will be your other options?
One is we can start on infusion.
No, one you can give 150 mg more bolus.
One more bolus.
One more bolus can be given. 300 and 150 you can give. Other things you can think of magnesium sulfate as an additional, whether it's a polymorphic ventricular tachycardia, and magnesium sulfate definitely have got an antiarrhythmic property. You can try magnesium sulfate. And other option will be the recent trending will be the double sequential defibrillation. You need to use 2 more paddles and you use double sequential defibrillation back to back. And we are giving a higher amount of current of energy. And we are trying to stop that this thing. And what are the other recent advantages? Role of beta blockers like esmolol for VF. That has been recent studies that been some response to beta blockers. But what we are doing here, there is some arrhythmia. Whether we are trying to stop this arrhythmia by giving some beta blockers. So these are the recent, maybe the recent trends in the last 3 to 4 years. A lot of research has been happening on this field for the refractory ventricular fibrillation. Okay. Sir, any points?
Okay.
So the patient is still in CCU and getting his post-cardiac arrest care. Okay. Fine.
How long? When what is to happen? How many days passed?
3 days.
3 days.
3 days. Okay. How about the patient condition?
Currently, he's again on ventilator only, recovering.
Full ventilation.
Sensory was slowly improving.
Okay, good.
Since he had a prolonged cardiac arrest, we are not very sure. He is not brought in immediately to the ER. 15-20 minutes after the collapse only has been brought. So definitely he would have some hypoxic insult. Since it was a VF and VT, there have been some perfusion to the brain. So when you ask me whether VF, VT or PE is better, VF, VT is better rhythm as compared to PE because there is no perfusion at all. Here there is some perfusion. So there might be, let's see whether he will improve or not.
So,
Age
60.
60. So as per newer guidelines, if you're not getting like a proper STEMI or anything, there's some type of neuroprognostication. So initially we start the patient on target temperature management between 30 to 36 over 24 periods of time. And during that time, we can go for a CT brain plane. There's not any acute bleed or anything. But the next day onwards, we go for like a rewarming. We try to bring back the temperature normal. This thing. And during this time, we start him on like EEG and all other evaluations to not any permanent or like a reversible damage. So by the 72 hours, we prognosticate the patient whether he is like in a reversible or a non-reversible state by like going for EEG and MRI and all other evaluations like that.
This patient had any comorbidities already dedicated?
He's actually after the family came, we came to know he had a history of CAD in the past also.
Okay.
Previously, he had a history of anstomy about 5 years back. It was conservatively managed, and he's on medications also.
What are the medications he was on?
Only on dual antiplatelets and statin, ecosprin, cloplet, and statin.
Any beta blockers?
No, not in.
Okay.
Okay, thanks.
Okay, fine. Thank you.